Welcome to Channel 17, the Town of Colonie Government Channel.
Hello and welcome to Focus on Health. I'm your host, Peggy Mello. Today's guests are Bernice McLellan, a certified nurse midwife, and Tisha Graham, a doula and certified childbirth educator. Bernice, welcome.
Thank you.
And Tisha, welcome.
Thank you, Peggy.
Tell me, how did you become a midwife?
I was a nurse who worked on OB, and circumstances led to my catching a few babies when doctors were delayed getting in. And I thought, and I was delivered by a midwife who was a significant part of why I became a nurse. So I thought someday I'll be a midwife. This was in the early 60s. And then I got married and had children, and my husband kept saying, if you want to do this, you should do this, because if you wait till the children are all grown, it could be too late, and then I don't want to hear you complaining that you didn't do it. So I went to school in Brooklyn to a midwifery program associated with the State University of New York. Stayed there for a year and came away with a certification in nurse midwifery, and then took my boards, and now I'm board certified and have been since 1977.
So you've been practicing for 30 years?
Yes.
Oh my gosh.
Wow.
And how many babies have you caught?
Around 3,000 babies.
That's a lot of babies.
Yes, it is.
Okay.
Yes, it is.
Tisha,
It is, yes.
tell me about yourself. You are a doula and certified childbirth educator.
I am.
What
And-
exactly is a doula?
Well, a lot of people don't know what that name even means, but a doula is a professional labor support person, meaning that I work with families, with women and their families, be it partners or mothers and sisters, when they are pregnant, and meet with them regularly and get to know them, get to know their visions for their birth, their hopes for their birth, their preferences for their birth, their fears, their anxieties, and then I'm available to that woman whenever she goes into labor. And when she goes into labor, she calls me, and I may then join her at her home or meet her at the hospital. And I'm with her during her labor and during her birth. And I provide physical comfort, and I provide emotional comfort, and I provide a continuity of care that women typically don't get anymore in obstetric care or the maternity care system, because there are so many providers with whom they visit throughout their prenatal care. So I'm one of the consistent people who are with her. As a doula, I'm trained to know how birth works and to be able to provide support for a woman and her family. It's not just for the woman and we push everyone else aside. We provide sometimes as much support for the father and sometimes as much support for the woman's own parents if they happen to be at the birth.
And a doula is very much a part of the care provision team for a woman through the continuum of her pregnancy. So she works very closely with the midwife or the physician and the nursing staff.
I do.
To make sure that the patient is really of the prime importance in her care.
Right. I go to prenatal visits very often with the woman, and I just really get to know her and her family. It's typically her and her partner, and do my best to help them through the passage of labor and birth and into parenting. We help them cross that bridge into parenting.
Now, how does one become a doula?
Well, doulas, somewhat like midwives, come to the profession in a variety of different ways. I personally came to the profession by having children and then being known and recognized in the community as someone who had had children and someone who had an interest and a passion and an advocacy around birth. And so women would simply just ask me, could you come to my birth? Could you help me? Could you be there? It was several years later I began doing that work that the credential of a professional or certified doula became available, and I went through an organization, and there are a couple who will provide a certification process. And you do a course of study, you have to read a ton of books, you have to take an exam, you have to attend several births, you have to demonstrate that you have skills and interest and knowledge in the area, and then you become certified. I also have to maintain my certification, which means I have to continue to attend professional conferences and continue to stay up to date on current evidence-based information about maternity care.
As do midwives. They have to continue their professional education to maintain their certification also.
Okay.
Yeah.
So tell me about BirthNet.
Well, BirthNet is an organization that we're very pleased that you invited to come on to the show today. We are an organization, a nonprofit organization in the Capital District that educates the public about maternity care, about issues around birth and pregnancy and postpartum, so that women and their families can be as best educated as possible about what their options are and what those options involve. Very often women aren't fully aware of what the options involve. For example, a woman might be encouraged to induce or start her labor when she's either tired of being pregnant or the doctor is planning to go on vacation. And it's important that a woman understands what that intervention is and what that procedure involves. So we serve the public in the way of providing education about women's options around birth.
And it's not just, is it just about birth, or is it about pregnancy?
It's about pregnancy.
Postpartum?
It's about pregnancy with regard to choosing care. For example, a lot of women that I work with may not know that midwives exist, despite the fact that we've come into the 21st century and midwives have been here since the beginning of time. I like to say they're the oldest profession. We sometimes say something else is the oldest profession, but somebody had to catch those babies. And the midwife is the oldest profession on the planet. And many women today in our modern maternity medically managed system of care don't even realize that a midwife is an option. So we provide information about midwifery care. We provide information that it's an option for women, as well as about the birth, as well as about some care for postpartum.
And I think they also educate the public that midwives are not the stereotypical care providers that they were maybe in the 20s and 30s, but that they're educated, that they work within the healthcare system, that they provide care across the continuum from 9 to 90. You can go to a midwife not only when you're pregnant, but to get prenatal care, to have your GYN exams, to do family planning, to have advocacy issues addressed, to deal with changes in the life cycle. It's a very comprehensive, but there's a lot of misinformation still out there about midwives and having to have a home birth. And whether a midwife is even able to do anything other than deliver babies.
I think that's a very good point, because very often, even if women know about the option of the midwifery model of care for their pregnancy and for their birth, they very rarely know that the midwife does provide that continuity of services from 9 to 90, as Bernice said. So you could bring your teenage daughter to see a midwife for her first GYN exam. Midwives are not exclusively, but tend to be overwhelmingly female. There are a couple of male midwives out there, but for the most part it's a guaranteed female provider. And as such, I think a lot of young girls and pregnant women and even older women feel more comfortable with that. So it's a very important distinction and a point to make, that midwives do provide that service for women throughout their entire lives.
And oftentimes with young women, if they're reluctant to talk to their mother about life changes that are going on, puberty, whatever, it's a little bit more comfortable to be part of a team, the mother, the daughter, and the midwife, to talk about what kinds of things are normal, what to expect from these changes, and how to deal with them.
Now, in your education classes, what other topics do you discuss? And
Well,
who do you actually teach to?
Well, as you mentioned, I'm also a certified childbirth educator, and I work around the Capital District. I've taught in many different places, and as an educator, I sort of promote the idea. I think the primary thing that I do is that I promote the idea that birth is a normal, healthy function of the female body, that it's not the pathological condition that it is sometimes been viewed in recent history. It's not a disease. It's not something from which women need cure or rescue. That it is a healthy function of the body, and it's something that women have been doing quite successfully, I might add, since the beginning of time. And I really try to impress upon women and their partners that birth has a very exquisite design, a very unique design, and it does work the way it's designed to work. And I try to encourage them to develop a sense of confidence and trust in their body's ability to birth normally.
And I think Tisha, oh God, I think Tisha also lets people know that there are no time constraints to this whole labor process, to encourage people to be patient with their bodies, that this is a process, and just like the changes in a woman's life from birth until death, these processes involve taking time. Each woman is different, and I think in our society we tend to want everything to happen quickly, especially those things that involve discomfort.
Yes. Well, the other thing I'd like to add as well is that in addition to sort of helping a woman understand what's happening in her body, what's happening with her baby, and what she can do to work with what's happening in her body, I am a very strong advocate of what we refer to, the lingo today is called evidence-based care. So rather than being an educator that stands up and has a personal opinion about various things, and I do have very strong personal opinions about a number of things, including issues in birth, it's not the proper forum for me to share my personal views while I have this captive audience who's kind of relying on me to give them information. My job is to share with them the best, most recent, current, up-to-date, scientific, evidence-based data that we have about birth. And I think maternity care, unfortunately for many women and babies, is one of the aspects of the healthcare spectrum that does not routinely practice evidence-based care. In other words, what we know works best, what we know is healthiest for mothers and babies, is not the way we practice, is not the way women typically experience the normal, natural, healthy birth process. It's very much wrought and complicated by common interventions that in each of their designs was made to help a woman and help a baby, but when imposed routinely upon healthy women, become complicating factors in women's birth experiences. And we have a very highly medically managed model of birth today, which is not what the evidence supports,
Exactly.
and it's not what the evidence suggests.
And I think it's governed by multiple issues. I think
yes.
it's governed by physicians who are trained predominantly in dealing with women who have complications
Obstetric
in the
emergencies.
abnormal, with a society that is very litigious, so
malpractice.
malpractice
The threat of
concerns.
malpractice.
More and more women are going into OB, and so their concerns are to be able to spend an appropriate amount of time with family as well as in their jobs so that they are balanced.
So you're saying when the woman is the doctor, is the obstetrician,
Right,
Yes.
right.
that they want to sort of limit their time or control their schedule. So
I
that
think
they can be with
control their
family.
schedules so that they can provide a balance of care. If you take care, you can't fill somebody else's bucket from your empty bucket. So if you make sure that you meet your own needs and your family's needs, you're a better provider. So I think there are multiple issues that come into play here. And some concerns about making decisions that are based on fear of lawsuit,
Right.
because there's a lot at risk. Not only your practice, but also your livelihood, your home,
Your children's college educations.
Right, there's multiple issues. So it's not an easy question to deal with, but I think our society demands that we speak up for those issues that are of critical importance. And interventions are not without risk. And I think our clients, the parents and families really need to know evidence-based information on what these risks are.
Right. And that's a very big component of what BirthNet is about as well. I mean, as we do community-based education programs in the Albany area, in the Saratoga region, in Colonie, all around the Capital District, we base our presentations and our handouts and our information on the evidence. What does the science say about what's healthiest for mothers and babies? Despite having probably the largest budget or spending the most amount of money for maternity care among all of the wealthy nations, the United States is not at the top of the list in terms of
26th.
our outcomes for mothers and babies. We measure outcomes, healthy outcomes with mothers and babies with numbers related to infant and maternal mortality and morbidity. We are not number one in terms of how we do birth and how well women and babies experience and survive birth. We're not 5, we're not 10, we're not 15, we're not 25. I think I have 28 countries
26 are ahead
do
of us.
birth
Yeah.
better than we do in terms of
And
infant
that's
and
maternal mortality.
maternal
So that's
mortality.
when the
Infant.
mother dies.
41,
baby.
41 countries do birth better than we do in terms of infant mortality.
mortality.
Now those numbers, though they move back and forth along the spectrum but never move up above 20, come from a very recent book that was published by a perinatologist, a fellow by the name of Dr. Marsden Wagner, who published a book last year in 2006 called How a Broken Maternity System Can Be Fixed to Put Women and Children First. So his statistics do talk about that breakdown in infant and maternal mortality and do place the United States very far down the line of many, many other developed and less developed countries that do birth better than we do. And that's it's kind of shocking.
What do you think would be the cause of that? I mean, how can the United States improve the mortality and morbidity figures?
I think bringing more midwives into the healthcare system, because a lot of these other countries, especially European countries, depend heavily on midwives to be the first line care
For healthy
for healthy
women.
women.
And it's
So
80% of babies outside
outside
of the United States
are delivered by midwives. Yes. And so the midwife sees the patient or the client or the mother or the family and evaluates their health history, determines whether this person has risk factors that require physician care, and the rest of, if the person is considered normal, then those clients see the midwife, and then they have an option whether they want to do birth at home or birth in a hospital or birth in a birth center. So I think that's part of it. The practice that I work in is very heavily collegial oriented. So our physician really depends on the midwives, and there are 4 of us in the practice, to take care of women who are normal, to consult him for any concerns or questions about risk factors. He does the high risk, and we do the
low
normal.
risk.
And the normal represents what percent of pregnancies? 90%?
Yes.
Are
Well,
normal?
I would say, if you're talking medical risk factors, higher than 90%. If you're talking about social versus and medical risk factors, then the number could be 85 to 90%.
And I think Bernice makes a very important point with regard to all of the countries that do birth better than we do in terms of our infant and maternal mortality rates have a higher ratio of midwifery care than the United States does. Our numbers, in fact, are completely turned upside down compared to the countries who do birth best. The countries who do birth best have an 80 to 85% midwifery model of care that's provided for its citizens, and a 15 to 20% medical model of care, which is what the statistics show it should be. So they're the countries that do birth best, they have the best outcomes. We do it just the opposite. We're lucky if we have a 20% midwifery model of care.
I think 16%.
It's around 15, 16.
16%.
In some communities, it's much lower than that. But to answer your question, Peggy, I think some of the other factors have to do with access to prenatal care. We live in the wealthiest country in the world, so-called, but we don't provide automatic guaranteed health care to all women and children. So access to prenatal care, let alone midwifery care, access to care, period, remains a stirring and shameful issue in this in this country.
It's not necessarily socioeconomically related. It's not representing the people that are down in the low economic areas.
Well,
it's also the rural areas as well.
Exactly,
yeah.
but for some areas the question is whether there are midwives and physicians even in the geographic
county.
area.
We have some
Right.
counties in New York where there's not even a single obstetrician, and women have to travel to neighboring counties for obstetric care and to give birth in the hospital. There are no maternity hospitals in several of the counties across the state of New York.
But the other issue is those people who, for whatever reason, don't have insurance, health insurance, and these people often are excluded from care because of their inability to pay. And that's one of the reasons why I came to work where I work at Seton, because they welcome everyone, whether they have insurance or not.
Now, you were telling me before the show, before we started our show, that there are some GYN offices that won't even accept patients without insurance.
Right.
I mean, to me, in my idealistic mind, not knowing much about insurance, I would have thought, well, if they can pay the bill, then why can't they be treated?
I think that some practices mandate that you show them that you can pay, and if you don't, that you be willing to sign a paper that secures a loan for you to guarantee the costs of your care.
And the costs are high.
Yeah.
I mean,
not everyone can do that, and it has nothing to do with, well, it has something to do with overhead, something to do with reimbursement, and that I think is a detriment to many physicians hiring midwives. Reimbursement for midwifery care in most private insurances or HMOs is 60% of what the physician would get for the same care. And often midwives are more geared toward preventative medicine, health and wellness issues.
and have better outcomes.
Yeah. You know,
So
so it's not just a simple, one-sided, one-tiered problem. It has many issues. It's very complex. But, you know, the best way to handle a complex issue is to take one part of it and deal with it, and then go on. And I think access to care is one of the major, because that's part of the reason for some of our bad outcomes. People do not have access to care.
So how much does it have to do with the interventions that are used? For instance, the drugs, the forceps,
There are a number of complications associated with each and every intervention that we use in a hospital for a laboring woman. As I said earlier, the interventions were originally designed to help, and I certainly do not, I agree that they do help, of course. It's a godsend, for example, that we can do a cesarean as well as we do with both mother and baby having a very high survival rate. But we use the cesarean, to use that same example, much more frequently than is medically needed. And so when you use a cesarean in a situation that it's not absolutely medically necessary, you tip the scale and the balance of, is the risk associated with the surgical procedure worth taking because of the risks associated with the mother and the baby who might be presenting with some complication or illness when we do surgeries that are not necessary. And a very large majority of our surgical births in particular are not medically necessary cesareans. We put women and babies at risk, and there's a higher maternal and infant mortality rate for women who have surgical births. So yeah, the interventions certainly can be connected to part of the problem. Absolutely.
And we talked before about the reasons for some of these surgical interventions, and some of them have to do with fear of lawsuit, fear of litigation. So I heard a physician once say, I will never be sued for the C-section I did, only for the C-section I didn't do. So what you're saying, what that person is saying is, I trust that I know best how to take care of this mother so that I can continue to provide care and not be sued.
Right. So very often a lot of what is done in hospitals with many practices, obstetric practices, has more to do with the protection and the liability issues and the convenience of the practice, of the provider, or the institution, than it does with the health and the well-being of the mother.
And we've changed some things. We don't any longer shave our mothers from stem to stern, so to speak. And we don't routinely give enemas. And we don't routinely rupture membranes. At least the midwifery component of the practice model of care doesn't. And we don't stick women on monitors and keep them in bed. The process, if you just look at the physics of the process, a woman who is looking to have a baby be delivered does much better if she's upright. So upright
meaning standing.
Standing or walking or being in a tub and moving and rocking, dancing. You know,
Belly dancing.
Yes,
We've seen it.
We've seen it. We've seen it. But the physics is such that it allows then the baby to come down into the birth canal.
Well,
and be
gravitational
gravid.
forces alone
Right.
will and the opening of the pelvis when a woman is in a variety of positions makes birth more likely to happen normally and vaginally than when a woman is lying flat on her back and working against gravity and pushing a baby through the most narrowest pelvis she can possess.
And I mean, think about it. When you use the bathroom, you don't lay across the toilet to use the bathroom. So why would you,
Yeah.
when you have something else coming out of your body, why would you lay
Be in
bed
any other position.
and then sit up? So,
Generally, the births are either squatting.
well, our
or
births are,
standing.
really it depends on the comfort of the mother. So we have some that mothers are lying on their left or right side. We have some that the mothers are on their hands and knees. We have some that the mothers squat at the bedside. We have some
Over the toilet bowl.
over the toilet bowl. One,
Basically, physiological is what you're saying.
yes,
Yeah.
yeah. So, but if the mother is comfortable on her hands and knees, we don't make her change her position.
And I think therein lies the definition of the midwifery model of care, or at least one of the aspects of the definition of the midwifery model of care is going with recognizing the woman's preferences, respecting the woman to know what she needs to do to get her baby out, and providing the support. I mean, I've heard Bernice say at birth, you know, I'll follow you wherever you go. Just, you know, as soon as you start pushing, just make sure I'm in the room. And she doesn't need to have a woman in the bed, on her back, up in.
We had a woman deliver in a shower with the water on, fourth baby. Her children were sleeping in the bed in the labor area.
Yeah, so they were somebody was using
Yes,
the bed.
but, you know, I said to her, can we at least turn the water off? And she said, no. So
There you go.
I was soaking wet. She was happy as a clam. We walked
the
out of
baby?
the shower with the baby and her wrapped in a blanket, and
And she already had her shower done.
she did. You know, but it's about flexibility, and it's about not being so concerned about your own issues and your own need to feel important.
Well, it's
that you can sit below. You can sit below the patient, so to speak, on the floor sometimes and catch a baby.
But it's also about, I mean, how difficult is it to get the right environment that is conducive to a comfortable birth?
We're working on that.
I mean, do you feel that the local hospitals have that down? I mean,
We're
do you
working on
see
it.
the
I think
majority,
some do better than
the
others.
majority of the patients, are they actually locked down to
It
their
depends
beds?
on
Are
their.
they on monitoring? They can't move?
It depends on the care provider. It really depends on the care provider, and those are questions that the couple needs to ask
Right.
before they
get to that
they
point.
get to that point.
And again, therein
Mhm.
again defines some of the differences between a midwifery model of care, which is an individualized model, and a mother-centered model, meaning the midwife follows the mother's lead and the mother's intuition, versus a medical model of care where the patient, the woman, follows the medical model, meaning here's how, there's a very particular way that we do birth medically, and that does involve a woman in a bed, on a monitor, not getting up. If she's anesthetized, if she has any kind of pain relief, pharmaceutical pain relief at all, which an overwhelming majority of women do, they're in the bed. They're
Because
done moving
the risks
for the
of
most part.
falling or not being able to control their limbs is
So
pretty
women are
significant.
very often, more often than not, I would say, in that position that perhaps is the one that you were asking about, that environment in which she is on a monitor, she has catheters, she has IVs, she has lines and tubes and tape and hoses, and she's pretty much hooked up.
Well, and I have to say, in fairness, that this is also about a mother's choices.
Oh, yes.
If the mother wants epidural, medication, whatever, she has the right. It is her body. She has the right to choose that. She just needs to know that if that's her choice, what the risks are, evidence-based again, and what the benefits are, and how that is going to affect her mobility.
Exactly.
And
So-
I would imagine it'd be better to inform the mothers when they're not in labor.
Well, that's what
Tell
Both is
Tell
all
them when they're
about.
pregnant,
And that's what
this is what's going to happen, and these are your choices, rather than, oh my God, I'm in so much pain, and
Right.
I can't think straight right now.
Advocacy is best accomplished when the couple are comfortable
Right.
and with information.
When you come into the hospital in pain, screaming for an epidural, that's not an informed choice. So we want women to understand, and epidurals are great. Epidurals are fabulous. They work. They get rid of pain. They work really, really well. But they're not that great for labor all the time because they restrict a woman's movement. They sometimes don't allow the baby in the optimal position, and sometimes they interfere with the hormonal blueprint of how labor works. They interfere with the body, and the body's designed in a particular way, and all interventions provide some element of interference with that system. So women just need to know that. And if they choose, as many women do, to have complete relief of pain, they also need to know that they will be completely relieved of movement, and they may be relieved of their vaginal births because there is an increased use of other interventions that go along with one. Often we have an intervention that leads to another intervention that leads to
They
another. We call
snowball,
that
sort
the
of.
domino effect or the cascade of interventions. And a woman ends up with a very highly medically managed birth. And she just needs to understand that's her choice, as opposed to, because a lot of times women say, I just want something for pain. I didn't want all this other stuff.
So what percentage of your births do you think include pain medicine?
Of all kinds, probably 50%.
50%.
And I think
50% are no drugs whatsoever.
Right, but I think the national statistics are
Or
at least
higher.
much higher than that.
I think we have an exemplary practice. I mean, I'm not tooting my own, yes, I am tooting my own horn.
As well you should.
But I think we have a practice that is exceptional.
Yeah.
That is really exceptional.
Well, because they provide the support when well supported. A woman, in fact, very often chooses pain medication, particularly an epidural or a spinal, for fear, for anxiety, not for pain. Once they start having pains of labor, they get pain, and it's intermittent. It comes and goes. They get that. But they have fear about the process, fear about the unknown. So when a midwife or a doula, or combined, can provide a system of care and an environment of calm and comfort, she does much, much better working with the efforts and the forces in her own body.
And I think the convenience of care sites is also important. Tisha is very flexible as far as going to the patient's home. But in our practice, we have a site in Clifton Park, we have one in Cohoes, and we have one in Troy where you can have midwifery care. And we have evening hours in the Clifton Park office so that people who don't find it easy to get out of work can come in the evening and be seen.
That's good.
Without risking their jobs.
Right. And as a doula, I do births in every hospital around the Capital District. And when I meet women in their homes, women having hospital births, I meet them there so that we can labor, she can labor, and we can spend more time in the comfort and the familiarity of her own home, because she does better there. She can eat to hunger and drink to thirst and move as she sees fit. And those are some things that she cannot do upon arrival to the hospital. Some of those things she cannot do. So we really encourage women to stay home. We encourage them to
The longer you're in the hospital, the more tempted the medical model is to intervene in your care.
So
it is good to be home in your own environment.
Right.
And I think women have, we have an obligation to let women know that they have choices as to their birth site, that they can interview and see which site best meets their needs.
And
as
the
far as
evidence
family.
suggests that both birthing centers and people's residences are as safe, and in some cases even safer for women than having babies in the hospital when they are not complicated by any illnesses or other obstetric issues. And so it's important for women to understand their full range of options, and that's what BirthNet really serves to do, ideally before women get pregnant. We even do classes at SUNY Albany. I do classes in local high schools. Some of our members do classes at the local colleges, and this is in most cases before women are before they're pregnant. And we just plant some seeds about taking ownership over their care, becoming informed. I mean, people make more decisions when they buy a washing machine than they do when they're having a baby in some cases, because they don't do the research. They don't look at the evidence. They just hear what their sister's girlfriend's coworker did, and that was the best thing for her, so I guess that must be the best thing for me. And women are shocked to hear that they could have had a midwife. They're shocked to hear that they could have had, gee, I wish I knew I could have had a doula. That would have been very helpful.
Yeah. But I was delivered by a midwife. I did not have that option in the community that I was living when I was having children. And now that I am a midwife, I really feel committed to ensuring that women have midwifery care options within the continuum of the healthcare system to advocate for their health.
And I, on the other hand, was raised at a time that midwifery care was available to me during each and every one of my 5 pregnancies, and all 5 of my children were lovingly brought into the world, into the hands of midwives.
Yeah.
So how can you advocate for, number one, OB/GYN practices to bring midwives in to their practices? And also, how do you get into the rural areas the maternity care that is needed? I mean,
I don't have the
grassroots.
I don't have the answers to
effort
all
there?
of those issues, but I think good statistics and programs like this that make the community aware of what's available is probably the first step. Good statistics is the second step, I think, and that's where you can show that the type of practice you're doing has good outcomes. People want to
good
come
track
where
record.
want to come where it's safe.
Mm-hmm.
As far as advocating for health care in rural areas where they're underserved, I think communities need to get together to encourage physicians to come there, because physicians come out of a medical school or pre-med and medical school and internships and residencies with an enormous amount of debt. And so they tend to go to large urban areas where the pay is better. So I think we've had a lot of success with communities banding together to hire a physician and then providing them with financial support while they get started, while people realize, until people realize that this person is an advocate for them. So it's a beginning. We don't have all the answers.
All right, so let's talk about a take-home message. Number one, this month's Utne Reader, is it March, April?
It's March, April.
Has a number of articles about
Yes, I referred to a
maternity
book
care.
earlier that had been published last year by Dr. Morrison Wagner. There's a spread in this month's Utne about birth in America. One of the take-home messages, of course, as Bernice had said earlier, was that midwives provide a continuity of care throughout a woman's life. The other take-home message, I think, is that doulas are available to women to provide support to them and to their family during pregnancy, birth, and postpartum. And from BirthNet's perspective, we are available to come and speak. We are available. We do community education projects all over. Our next program in April will be held at the Albany Public Library on April 17th, and it happens to be on midwives. Midwives, experts in normal birth, and we'll be talking at the Albany Public Library, and we invite anyone and everyone who's interested in BirthNet or birth issues or maternity care
Or midwives.
or midwifery to come and join us at 7 o'clock on April 17th. I think it's a Tuesday evening, and we'll be talking about birth. We have a Let's Talk About Birth series, and we take it all over.
Okay, and you also have regular meetings at the Colonie Library as well.
Well, we have, our Colonie meeting is an event that we're doing in the month of March, which focuses on getting the kind of support that women deserve. And so our topics vary, but they all come under the umbrella of evidence-based maternity care, what couples need to know when they're having a baby in America.
And we're going to show the contact information for BirthNet.
Great.
And also selected books.
Great.
The information for selected books
Right.
once the show is done. Thank you very much for coming.
welcome.
Bernice and Tisha, you've
Thank
been
you, Peggy.
fabulous. And you guys do really wonderful work, and you're an amazing resource for Capital Region women and families.
Thank you
you
so
for
much for
having
having
us.
Thank you for watching. We hope to see you next time on Focus on Health.
Welcome to Channel 17, the Town of Colonie Government Channel.